Welcome back, everybody, to the Vitality Code podcast. I am Dr. Jason Farrah, joined today by my well-bearded co-host, my brother, Dr. Jeffrey Farrah. Say hello to the folks at home.
Good
How you
morning,
doing?
sir.
Hey, I want you to notice something.
I'm good.
You're doing good?
I'm doing good. What's going on? What do
Okay,
I got to
want you
notice
to look.
here?
I'm taking one for the team today, everybody. Look at this.
Oh, jeez.
I'm not letting anything stop me from bringing you guys the show. Look at this. Look at this. Look at the zebra stripe on my forehead. See the white, the red, white, red. So this weekend, our Knowles. What about that game, baby?
That's right. Yes,
it was a sloppy game, but it was good.
You blew me up with.
I was blowing my brother up at the game. Me and the kids were out there, and I was screaming like a maniac in the hot sun and stormed the field. Death Valley. That was an experience. The first one over was Jax. Jackson was the first one over. I said,
"Oh yeah,
he just went for it. Attaboy. Some cheerleaders helped him over.
Well, Dad told me to storm the field, so I did.
What are you doing down here? Yeah, it was awesome, man. It was awesome. And then I also, for you, Jeff, look what I did. Do you see this? Goochland.
What is that?
This is my.
I can't quite read.
This is my Oliver Anthony swag. This is the brand of shirt that he's wearing in the now eponymous or famous or whatever you want to say. Recording of
Richmond, north of Richmond.
Yeah, look, I think producer Nick's going to bring it up. Watch this. Check this out. Goochland. I did this for my brother who introduced me to this song.
That's right. Yeah. I said it to you. What I tell
and
you.
You said no.
Song of the year.
You said song of the decade, and you were right. It is. And then after that, I said, "Wow, this song actually is really good." It made me laugh, made me cry, the whole bit. And then I start seeing on YouTube, right, everywhere. Oh my gosh! Have you seen the reaction to the song? Honestly, now we're a little bit late, I guess, in the way the media is and our world is. But we should have been mentioning this maybe 3 weeks ago. But wow, what a reaction! Did you see, Jeff, on YouTube all the reaction videos and the?
I don't know if I watched reaction. I watched a couple of them for sure. It was good to see because sometimes in that vein, you feel like, oh, I'm the only one who this resonates with.
I'm glad you said that. I'm glad you were honest.
Ages and sexes and races.
I'm glad you were honest and transparent. That's interesting that you just did that right now. That was completely organic. But because I honestly, on a serious note, I felt the same way. I was like, and I'm not. This is not what the show's about, and we're not trying to make a social commentary or get into conspiracy theories and everything like that. But my gosh, I will tell you this: that everybody feels the same damn way, right? I mean, like, good Lord, and it resonated with a lot of people, obviously. So I
don't think it's conspiratory that the Richmond, north of Richmond,
want
nothing to do but for themselves. I don't think that's conspiracy.
Yeah, there might be some pharmaceutical people up there too, in the same circles, right?
Yeah, good Lord.
People in medicine and all walks of life, and it doesn't matter. But yeah, I thought you'd appreciate that. So, see if producer Nick, can you get a picture? Can you actually just real quick? Can you get a picture of Oliver Anthony wearing that shirt?
Oh yeah,
is that possible? And while he does that, let's see what he can bring up. But let's see while we do that. Hey, so the first episode was a doozy. It was good. You kind of caught me off guard a little bit, buddy. So I thought I'd return the. Yeah, you did. But see, there we go, Goochland, baby. I'm one with the, and we got a person on our podcast that can rival his beard. Man, I don't know who does it. You know what? This might be the first person I've seen that can rival the Jeff Farrah beard. Jeff, look at that beard.
I bet I got more product in mine.
But
his is probably all natural.
Just by proxy, for sure. By categorically speaking, he's not going to put that kind of product. But look at that. His is all ginger. Yours is shades of ginger, but his is full on ginger.
There you go. We'll be able to tell how famous he embraces it by how his beard looks week to week.
That's right. If
it gets more refined,
there's more product in it, then he's moving up the echelon, the social
ladder. That's right. Yes.
That's awesome. But yeah, that first episode was good, and it was really interesting to dive into some of that. And I thought I'd just bat the ball over the net and send it your way. And let's take a little walk back in time.
All right.
And I think it's unique, right? I think too, one of the cool things about this podcast, at least for me, is that we're going to try to be transparent with our lives, transparent with our thoughts, as best we can see them. And we try to, I don't, it's a conscious thing, but maybe more is subconscious, that we're just taking our lives as lay people experiencing the world around us, but through the lens of medicine that we both practice, and the different types and the different things that we've been exposed to, and try to bring them to you guys and see if it's helpful. Again, and by the way, I want to put on record too that this is not medical advice. Nothing that you hear on the show is medical advice. We are two doctors discussing back and forth the latest issues in medical research, medical disease, or excuse me, medical research, disease, health, maintaining wellness through aging, vitality through aging, as we see it in our practices. And so, what we say with a patient one-on-one would constitute recommendations, but that's in a private patient-doctor relationship. We do not consider this podcast to be a private patient-doctor relationship. We are not giving medical advice. I will say, however, that hopefully it stimulates conversation, right? And we want to do that. We want to bring these issues to the forefront. We want to kind of give our insight into it so that you can then take that and talk to your own provider one-on-one. But I want to make sure that we're not specifically using this platform to give directed medical advice. Do you agree, Jeff?
Yeah, I mean, it was never my intention to give direct medical advice because there's so many variables that are individual to each person. And there's always issues that need to be discussed in prior history and things that are very individual to a person, whether they be genetic, whether they be previous medical history. But nonetheless, I think since the COVID era, if you want to even say that, it jump-started sort of this self-investigation, better understanding of science, better understanding of what's going on, learning to question. And so maybe if we can facilitate more questions, as opposed to, I don't want to create a scenario where you were reliant on somebody else's information and you felt trapped by that, and then you just transfer over to us and now you're reliant on our information. That's not the intent. I'm not trying to give you medical advice. I'm just trying to give you some things that will stimulate more questions that maybe you ask your doctor. Maybe you trust in your doctor more because of it, because you realize, oh, I used to wonder if you were telling me the truth, and now I'm hearing some independent review that sounds similar to what you were saying. And maybe you simulate a conversation and a question with your doctor. So yeah, no medical advice by any means, but just a way to see through our lens how we're seeing it from a patient perspective, from a medical perspective.
Yeah, well said. That was well articulated. Well, so let's roll back the curtain a little bit. I mean, all my life growing up, it's interesting. I think about the way I thought about it as growing up. We grew up in a family that didn't shun allopathic medicine, but definitely was open to osteopathy, chiropractic, alternative medicine, natural medicine, those things. So from a very early age, we both were at least open to it. And you ended up going down a different route. Started out, I think, in undergrad, right, at FSU. And no, actually at Jacksonville.
Yeah, originally I started out undergrad at Jacksonville. Yeah, I started out business major when I went to JU. And then when I transferred in my sophomore year, so I did my freshman and sophomore year at JU. And then when I transferred, I changed majors at that point and did exercise science. So that was like my first dipping my toes into the water of health, I guess.
You went to JU on a football scholarship, so you were playing football and thought you wanted to get into business. You were living a life prior to that in high school, and it's pretty intense. I mean, people that have been in high school athletics. I mean, again, it's not college, it's not professional football, but even at early age, obviously, I think more and more. I mean, this is pretty obvious that it's a pretty competitive thing, and you guys, correct me if I'm wrong, I think you were in the championship game in high school for your for your classification 1A or 2A. I think North Florida Christian was 2A.
We went to a small school, yeah. So we won the the state championship.
But we're in it twice.
For
so pretty competitive. And
division.
So, interestingly, you were focused, or maybe not so much as a teenager, but on your health and doing all that. But actually went into business. Was it just something that you thought, sounds like the right thing to do, or was it a practical decision, or was you really truly interested in business?
I don't know. I mean, I'm looking back at that point. I don't know what I knew as an 18, 19-year-old making those life decisions. I think I've always liked business. So, I mean, as I look back, I think I have more of a business family background. I mean, we did everything from, I mean,
That's
I went
true.
to flea
That's true.
markets. We had booths. We sold baseball cards. I
That's
sold
so
candy
true.
in school. We made things with our neighbors, and we'd take them and sell them. So what I remember from my childhood was more of a business perspective, always hustling to make a buck. As a young kid, I remember actually getting in trouble. I don't know if
Oh,
you remember this, but those candy bars that you sell door to door for
oh
a school
gosh.
fundraiser.
World's finest chocolate.
Um,
The world. It's
World's
the world's
finest chocolate,
finest.
baby.
Yeah.
I think they're still the same. It was $1 a bar, and I was selling them around the neighborhood for $1.50, pocketed $1.
Wait,
How
wait, wait. You were
terrible is
pocketing.
that?
You were
And I
pocketing
got in
50 cents. Let me
trouble.
correct your math there.
50 cents, sorry. 50 cents, yeah. I pocketed the extra
That
50.
is
And I can't remember
hilarious.
if mom and dad caught me or if one of the neighbors caught me, but I got in big trouble for that.
Wow.
So that was my first foray into
You were
corporate life. I was stealing from the
corporate
shareholders.
greed. Wait, so you were up marketed. That's hilarious. Wow, that is funny.
Yeah.
How far do you remember how far you got? Was that
But not very far. Come on.
Wait a second.
I was probably like 7 years
A
old, right in
dollar,
the third
a dollar.
house.
Every other kid's come by here before you was $1. What changed? Inflation.
It was not the best laid out plan.
Oh, but you've always been interested in circling back around now. I think that you own your own practice and it's multidimensional, especially and you're in multiple different modalities. It's probably coming useful, but somewhere along the way you said, no, I don't really want to do this. And that has seemed to coincide with leaving Jacksonville University and going on to Florida State. Is that right?
Yeah. I think I really liked football for what it offered me, but I found out it's there's levels to it. You know what I mean? People say that there's levels of this game or whatever, but man, when you go to being a big fish in a small pond to now being on a college campus and everybody's just as good or better than you, and also it is now a job, right? It was even at the small level that I played at. I can't imagine what a Florida State or a UF or a tier 1 school, but it's a job. You get up early, you have to go to classes, then you have to meet, you eat together, you do study hall together, you have to go to film together, you have to go to after practice together. So it quickly became a job that I realized that maybe I was not going pro. I was not going to make money at this. And I was sort of beating my body up, and maybe it wasn't the right choice. I enjoyed
It's interesting
aspects of sports, and I really do like sports, but when I became a career oriented position without pay, you know what I mean? Like it was like, maybe this is not the right thing for me. It changed the whole aspect of it. The pressure mounted, and I was like, so when I switched to Florida State, that was the only reason I was at JU. When I changed to Florida State, I kind of wanted to keep that aspect of it. I wanted to be involved in some sort of athletics, being involved in some sort of exercise and fitness. I just really enjoyed that lifestyle. And so I thought, what better way than to start learning about it? So I remember in my first semester, I just took Anatomy Physiology 1 to see what it was like, and I really just kind of fell in love with it
really?
from that
That's
class.
interesting. Okay. So what about it? What about it kind of
Yeah.
resonated for you? Just
I think my instructor, I still remember, I can't remember his name, but I could see him. He was a college level athlete. Prior to, he was a soccer player. So had maybe a similar take on things. And so his anatomical perspective was that of an athlete, so a lot of examples in class and things like that would be maybe related to me. It was a tough class, really tough class. He was a tough teacher, but I kind of thrived on that pressure a little bit. It gave me some of that pressure from athletics. And I prided myself in maybe the fact that you're setting the goal and then that goal being an A in this really tough class with this really tough professor, who had a little bit of that sort of athletic coach mindset in academia. And I just kind of liked that pressure a lot. I liked him a lot, and I liked the material. So it wasn't arduous for me to study, and I just kind of really enjoyed it. And I was like, oh, this is really cool. I think I'll take it a step
That's
further.
very interesting,
And so then I
actually.
kind of changed my major.
To unpack that a little bit, so you, it seems like you, it seems like you like figuring things out and how things work. Would that be true? And then,
Yeah, for sure.
and like the
Yeah, I like the
process
process.
and the truth of it too, right? Like, like, because I mean, I think what I mean by that is like you, even though it was difficult, you you drew closer to it, and like it seems like you continue to do that in your practice today, and you've continued to do that with your own self education. And we're going to get into that a little bit when you went on to become a nurse practitioner. You kind of diverged from chiropractic over to back to allopathic, and that was actually a huge, was not easy task to do. But I see some people, I perceive, and I even in myself. So I want to implicate myself as well. But you get into clinical practice, and sometimes it's easy to take things at face value. And I think COVID really brought this to the forefront to me. Oh, well, the researchers are saying this, so that's what it is. And you can spout off a few of the proteins or molecules in the signaling pathway, and you feel like you got a good understanding, and that's that, and that's what it is. But if you're honest with yourself, you'll say, I don't know if I have that true deep understanding. And also, there may be things that you see that in your clinical practice that are incongruent with what are said in the classic literature. So my question to you is, do you think that you've had that same experience? And then number two, do you think that that dovetails with your own pursuit of truth and that kind of that being in love with the process and the argue,
Yeah, for sure. I think, it's it. Speaking of the research, and then what you see, you see in some white papers, you see in research, and you see in the classic literature, and then what you see in practice, and sometimes those don't match up. Um, I think it's important to, I tell sort of myself I don't trust anybody when I'm looking at literature, and so I throw myself in that. I need to be careful and check my own self, like, oh, this is the way you do it. Oh, you've got low back pain. This is the best way to treat it. Always with a grain of salt in the back of my mind. Let me go check and make sure someone's not proving me wrong. But then at some point, you need to trust what you are seeing. If you have a true objective sense of what's going on, you need to trust yourself as a clinician, and that's a delicate
gosh,
balance
that's so
too. So you're
true.
always kind of questioning, you're always kind of
Yeah.
trusting, you're kind of balancing that and finding out what's best, and then ultimately it's what's best for the patient. I tell, I don't like this statement I hear and I've heard commonly in medical communities. I see it more in the allopathic, but the comment is, I would like you to take this, I would like you to, and I just struck me weird, is like, why why would I like you to take this cholesterol
Hmm.
medicine? I don't like for you to take anything. If you came to me and you said, "Hey, I'm interested in this medication or this problem. Is there something that will help me?" And my job, as I see, is just to lay out the evidence. Here's some pros, here's some cons, here's some pros, here's some cons, here's a different avenue. Which one of those looks like the best avenue for you? And then to play devil's advocate, to understand the research a little bit, to lay out some of the pros and cons, and then we make a decision together. I don't like the
The
top down,
paternalistic, yeah.
well, you should do this because, and I find that a lot in medicine, and that to me is, I really practice out of a three circles that intermingle. It's my experience and what I see with my patients, what the patient preference is and the patient desire, and then what does the research say. So where do those three meet? But not one of those is
Right.
100%,
Kind
right?
of like a Venn
Um,
diagram where they intersect.
you don't just say, well, yeah. You don't just say, oh, the research says this, so you have to do this. And the patient's like, well, I don't want that, And if the patient wants something, but it could cause imminent harm to them, then maybe I need to be aware of that and sort of, well, here's the research, here's my experience, my practice. And then if you say, well, in my experience, in my practice, it says this, but the research is consistently saying you're wrong, you're wrong, you're wrong, you need to step back and make sure you're not skewing those practice results. And so, kind of finding, always in the pursuit of that
Yeah.
truth, like you said.
Um, well, so when you were in college, you kind of had a circuitous route, right? And I think it was
Very much.
exercise physiology first, right? And then there was then you went to master's for kinesiology, or am I mixing those?
No, I did exercise science with a emphasis on
Okay.
fitness and nutrition. That was my undergrad, and then I went for my master's in exercise physiology, and
Where was
that
that
was
at?
the master's program down in
Oh,
Miami,
Florida
FIU
International.
in Miami,
What was that like? Were
Florida
you happy with
International.
that
Yeah,
program? Were you?
yeah. No, it wasn't the right program for me. I liked exercise science. I really liked fitness and nutrition. I really wanted to take it the next level, and that was not a master's in exercise science. It's a master's in exercise physiology. It was. I think I learned pretty quickly though that I was going this route of becoming either a strength coach or becoming a clinical sort of like working in a hospital, doing stroke rehab, doing like exercise physiology. And neither one of those seemed to be the right approach for me. I did a couple internships. I went up to Northern Arizona University and having a Olympic training facility up there, and kind of took the researcher. It was sort of like if research met strength coach. Olympic athletes and Olympic teams go up there because it was at
Oh,
high
wow.
altitude, but it
Cool.
was a plateau up in Flagstaff, Arizona. And so they had a prolific training facility, so to speak. So we had a lot of swimmers, a lot of rowers, a lot of runners that would come to train. And we had a base of athletes from which to study. And so I worked with the research department there it was actually a grad program I did in my undergrad a semester. And then my FIU advisor was a strength coach and was doing a lot of strength research. And when it got time closer and closer and closer to graduation, I realized I don't think I want to go the strength coach route, because there's a lot, in my opinion, the business side of it's really not ideal. There's like one position and then a lot of free labor underneath that triangle, and you got to do a lot of free labor to get up to the peak. There's only so many teams that have a paid strength
Right.
coach, right? And then you're doing a lot of GAs. There's only so many pro teams. There's only so much. So it didn't seem like something that I wanted to do. And I learned, I think, also that I really liked being the athlete, but maybe not being the coach every day. I really liked the substance. I really liked the performance. I really liked the analyzation, but it wasn't necessarily something that I wanted to disseminate and be the coach or the leader of. I liked being a participant of
Do
it
you
more
think? Do you think you
than
didn't
I
like to be the
liked.
coach, or you didn't like to be the coach of that population? Because you kind of
I
coach now,
don't.
right? I mean,
Yeah, I
in
don't.
some ways.
Right. Yeah, I coach now, but in a different sense. Like I don't think that career coaching was for me. Like personal training, I did that as well on the side. I like those concepts, and I like the academic, and I like exercise, and I like the academia around exercise, but it it was not the career choice for me. I prefer one-on-one relationships. I
Mm.
prefer a little bit deeper dive into at that time for me, the science of it. And I just wanted to take a next step um, in that medical side of it rather than
And
the
people that were
exercise side
coming
of
to
it.
you for your expertise rather than were stuck with you for your expertise. I wonder, right? Because if you're a GA and you're the strength coach, I mean, those players didn't have a choice in medical practice. They're coming to you seeking truth, and I think there's a difference in that
Mm-hmm.
relationship. I know that's how I would have experienced it, and I don't know if
Yeah.
that's the same for you, but that's interesting. So this is interesting, and I think we've talked about this a lot. And the cool thing about, I guess, having a brother that you can, or a family member that you can speak with a lot, and that is in the similar fields, and you can bounce back, ideas back and forth, and have this Socratic exploration of it sounds so pie in the sky, but of truth. And but I mean, really, I mean, I think we both challenge each other in that way, and I've always been appreciative of that over the years. But uh, here you were getting this master's degree, and as I recall, I think I don't know that you ever finished and made a quick about face and said, "Hold on, like you just said, I'm not sure if I want this kind of job. Uh, I think I
Mm-hmm.
want to do chiropractic." How to unpack that for us? Explain what happened there.
Yeah, I was in my last
The
semester of
very
my
end, the very
exercise
end,
physiology
right?
masters. to the end, right? Yeah, it was a non-thesis program, so I was down to the very end, and I sort of maybe had, it wasn't like a midlife crisis or freak out, but it was like a sudden realization, and I was like, well, if that realization is true, regardless of how sudden it is, there's no point in continuing this, right? Because then I'm pigeonholed into this career to a certain extent. So I about faced pretty quickly, unenrolled from all my last semester of graduate classes and enrolled in all my prereqs, which was like I had to do some chemistries, I had to do some biochem, and I think it was like a organic, a biochem, and one other class that I didn't have in my fitness and nutrition side. And those were prereqs for chiropractic school. I enrolled in those last semester of grad school. They were undergrad classes. I was still enrolled at school, so I could just enroll. No one caught it. It's a big institution.
So you were actually a master's student now going in there with undergrads. And nobody said, wait a second.
Correct. Yes.
just flew under the radar with that one.
Yeah, I mean, I think big institutions, this, and anybody that goes to a large school, there might be 1,500 kids in a class. How can a professor keep track of any of that? Your TAs, and it breaks down. So I just quickly unenrolled and enrolled in those ones, and got my credits, which were necessary, classes rather, that were necessary for my undergrad, or for my admissions to chiropractic school, and then enrolled in chiropractic school.
Was it one semester, or did it lengthen the time that you would have otherwise been in school? Did you knock all that out in one?
I don't remember exactly. It may have been 2, if I remember correctly. Probably 2, but not 2 full semesters of work, but probably 2 because of the way classes are offered. Only some are offered in fall, and only some are offered in spring. And so I think I took probably under 5 classes, maybe up to 4 classes, and got those and applied to chiropractic college. Applied to 2 of them. I applied to Palmer, and there's a couple Palmer campuses, but I applied to the Palmer in Daytona Beach, and I applied to Australia. Those are my 2 choices.
Wait. All my eggs. One was in the U.S. and one was in Australia. Seriously?
Yep. I probably didn't tell anybody.
I've never heard.
They have a pretty good manual. I didn't tell anybody. They have a really good manual therapy scene. I like to travel a lot. I wanted an adventure. I was young, and I was like, all right, let's do it. And the acceptance date for Palmer, I got accepted, and the acceptance deadline came before I heard from Australia. And there's a lot of hoops to jump through, obviously, I think, going to another country. And so I was like, not if I turn down this acceptance, and then, you forgot this immigration paper, or, you forgot this form, just common things that happen with any application process. And then now you're pigeonholed and wait another year or something. So I just took the acceptance to Palmer in Port Orange.
You do like to travel, and that's interesting to me, actually, because let me make sure if I have this right. If we looked at your life up until that point, because that was a big leap. So a couple things occur to me that there's this concept of don't trust the process, don't rush the process. You trusted yourself, you trusted the process. You invested all this time and energy. You were in a master's degree program, had gone out to Arizona, Flagstaff, Arizona, to train with, research, and observe Olympic level athletes at a very unique training center. Thought you wanted to maybe be a trainer of that type of or classification of athlete. Got back to Miami, where you were doing your master's degree. At the very last second, made an about face. Still didn't drop. Stayed with the process, and knew it might lengthen time or may not. But it certainly would change things, because you were going to go into chiropractic medicine. You wouldn't just go into a job. Then that meant more school, and then weren't afraid to apply to I didn't even know this, out of the country chiropractic school. And at that time, as I recall, you had. You've been to Pamplona to see the running of the bulls, right? You stayed.
Sure. Yep. Well, that was actually
at chiropractic school. Where was the time that you?
What was the time that you?
That you were? But there was one time you were out in a field somewhere in France by yourself camping. Went to see the.
That's when I went. That was in chiropractic school. We went to Europe, and I saw the Tour de France. I went to see Lance Armstrong win his last Tour de France. and I went to go see the start of the race. And I was the only one in my group that wanted to do this, so I went by myself and just hitchhiked up to the small little tiny town in outskirts of the French countryside. And when I got there, it was literally the tiniest town that you can imagine. And like if you can picture the U.S., it was like a small southern, one stoplight, one gas station. It was obviously a French version of that. So there's 0 hotels, and I mean it's obviously a worldwide event, and there's campers for miles and miles and miles and miles, and then here I am, speak any French, and I'm just like, oh, so there's not going to be a hotel. That was dumb. So I found a general store and a tent, and I bought a tent and pitched a tent out in the fields, just in some random field, and slept out there, or whatever version of sleep happened that night, and got up the next morning.
There was no blonde hair, blue eyed French girl with flowing skirts, with a basket of baguettes.
Yeah, whatever the movies tell you.
And she says you can stay in her dad's farm in the loft, and then she sneaks in at night to romance you. Exactly.
Yeah, Hollywood.
Wow.
Hollywood ruined that. That does not happen. The French people were very nice. They gave me plenty of rides, but there are no French models waiting to invite you into a warm house or anything. Like you're sleeping in a cold field in a tent with no pillow and no, yeah. And but it was great. So yeah, I think travel has always been a love of mine. So the idea of traveling overseas for college just seemed to be exciting, and why not?
We'll have to get into that sometime. I want to hear more about that. I know that's what we're talking about today, but there's probably some lessons in there besides Hollywood's.
Yeah, I think you're right. I think the big lesson for me is like, no matter what I was doing, I was always falling forward, right? I wasn't like, oh, I just wasted my time in my master's program, or, oh my gosh, what am I going to do with my life? I was just like, well, we're just going to keep taking steps. These steps are part of the process. I legitimately didn't know what I wanted to do, quote unquote, with my life. But I knew that was a good thing for me. I knew it was a good time for me. I don't regret doing those things. They've played a role in my future career, my future life. I had interest in those. But the time came where it was obvious to me it didn't serve the purpose, and so I made a transition. But that transition was not looking back as this was failure. It was looking forward as like, what's the next step?
You're building.
And the same with nurse practitioner, Yeah, like I practice mostly nurse practitioner work right now, but I don't look back at my chiropractic education as wasted time. Or it was, I did massage before I went into chiropractic school. I did chiropractic before I went to nurse practitioner. And so those all helped inform the future self. And I imagine in 5, 10, 15 years, I'll be doing something different that the nurse practitioner will inform. So I'm not going to look back at this time and think it was a waste, or I should have just known what I wanted to do. And so whenever I'm counseling people, oh, what should you do? Should you do PA? Should you do NP? Should you do this or should you do that? The answer is sometimes, like our dad used to say, is just make a decision and then make it right. So you can't get stuck in that decision-making process. And if you had asked me when I went to undergrad, are you going to be a chiropractor? And I'm like, I don't even know what a chiropractor does, to be honest with you. I've been to one or two, but I couldn't tell you what they even do. And then fast forward, then I'm practicing it. So, and at that time, I wouldn't have even known what a nurse practitioner was, right? And so I just kind of kept falling forward and making those decisions and mitigating any negative from those decisions. Like I didn't get massive college loans in undergrad. I paid for everything. I cash flowed things. I didn't take out my college loans to buy cars and do all this stupid stuff. So there was really no negative repercussions of it. And all that information ultimately helped me.
That's huge. And for the audience at home, that's huge. I think, and, I was sitting here thinking in my mind, was that did your mindset develop as a consequence of it, or was your mindset there and your reaction to it developed because of your mindset, and then that laid the foundation that you would fail forward instead of fail backwards? And I think it's the latter. I think it was the mindset, because not everybody has a failure and then goes on. Clearly, some people can get stuck in that and devolve and fall down this rabbit hole, or not rabbit hole, but this kind of downward spiral because of the decisions they made. They may look at their not making the master's degree as failing, seeing their peers go on to finish their master's degree and get these jobs, get married, get whatever. And you just said, no, that's just the next step in my evolution. And whatever now I will say, maybe you can't articulate it at that age, but the mindset, the fundamental core mindset's there, and you move forward. You know, golly, we got to get a microphone for Nick, because Nick's been through some of this stuff
So
too. I mean, that is a really interesting thing. So you went to chiropractic school, and then do all chiropractors practice the same? And if not, how have you practiced over the years?
that's a good question.
I mean, because there's different schools of thought, right? That's all I can remember of chiropractic.
Yeah, that's true.
There was like wasn't Palmer one of the fundamental guys, and there was a split or something? Or am I making that up?
Sure. Yeah. So chiropractic kind of evolved the same time as osteopathic medicine, Still and Palmer were two
Still and
practitioners
Palmer, okay.
around similar time, and yeah, orthopedics kind of went the route of more traditional allopathic, but they still practice manipulation. But they do surgeries, and they're primary care physicians, and they participate in the traditional allopathic with, as far as I understand, I've never been there, but with the inclusion of doing manipulation, spinal manipulation. Chiropractic went the opposite way and chose to not participate in allopathic medicine, not to get swallowed up, not to. And one of the things I think chiropractic doesn't do well is it's hard to, you go to a chiropractor, that's it. You don't know what kind of chiropractic style they practice. You don't know what their specialties are. They're just chiropractors. There's no subdivisions of boards. There's no internist versus cardiologist versus endocrinologist version of that.
There might be ones that use a little metal.
And so I would say it's like
clickers, and then there's the ones that do
the little clicky tool, and I'll offend people when I say that. And yeah. But you don't know that. And so I think it would be like if you walked into a doctor with a heart problem, you're like, oh, sorry, I'm a podiatrist. And you're like, oh, okay, let me go to the next one. He's like, nah, I'm an endocrinologist. I don't do anything with cardiovascular or, your blockages in your heart, So, and when you go in chiropractic, it's hard for the patient to understand that and find that. And there's a lot of overlap between a lot of chiropractors. And so sometimes they seem similar, but for my style of chiropractic, I was a pretty strict orthopedic practitioner. So there is the traditional straight, would maybe be the lingo we use, chiropractor. And then we have what mixers or the newer age chiropractic physician. And there's kind of differences within those. But the more straight chiropractic would look at chiropractic medicine and the manipulation of the spine as an avenue to complete health. It doesn't matter if you have diabetes. It doesn't matter if you have cancer. It doesn't matter if you have X, Y, or Z. You use your only tool in chiropractic education is manual manipulation of joints, specifically spinal joints. And then the other side of it would be more of a mixer, kind of newer generation of chiropractic, where you might use a massage therapist in your office. You might use exercise modalities. You might use spinal manipulation with manual manipulation of soft tissue. You might use X, Y, or Z modalities included, whereas the straights tended to practice just manual.
Now pause here for a second. If you've got the straights and they're kind of like old school, is that kind of, or is that too, or that might be too reductionistic?
That may be a way to think of it.
But then there's the mixer.
There are still current practitioners doing that. Certain schools teach a certain way.
So do the mixers treat? So it looks like you've got a range of orthopedic diagnoses that you can treat with spinal manipulation and the kind of the more straight, and then there's orthopedic diagnoses that can obviously be treated with soft tissue manipulation, spinal manipulation, and that's mixers. If you do them both, is that correct?
I would say your mixers, your newer genre of chiropractic would treat orthopedic conditions. Your straights would treat
okay, that's what I'm trying to figure out. Okay, thank you for that clarification. So where you went to school, were they telling you to treat any condition, or are they telling you?
So my school, Palmer, I thought, they did a really good job. It was you had access to both of those practitioners within the same school. So we had really, really, and people who aren't familiar with chiropractic or haven't been to one, there's the straight chiropractors. You might go to them for anxiety. You might go to them for gastrointestinal issues. You might go to them for nausea, vomiting. You might go to them for heart condition, right? Spinal manipulation. Those are really strict. We had those instructors. And then we also had really progressive practitioners who are like, no, that's silliness. Here's the way that you apply spinal manipulation for orthopedic conditions. Here's the sweet spot. Here's orthopedic diagnosis. Here's tests you should do for SI joints and elbow joints. Here's what you should do for a facet. Here's what you should do for a disc. and so we had both of those practitioners in the same school. And so I liked it for me because not knowing this before I went to chiropractic school, it kind of let me see
Okay.
both sides and kind of like gravitate and question. I like to question. And so I would call you out on this and I would call you out on this. And I could see who kind of formulated what I considered a better argument. And so for me, that came out to be more of a
I
orthopedic
see.
application
Okay.
of chiropractic
And
medicine.
so you ended up being a mixer, so to speak.
Yeah, that's probably an old term. You know, I
The
don't
new
know what
kids.
the new kids are calling it, but yeah, that's we called it
Is that
straight
really
mixers.
what you guys called it?
So your
Like you and your
straight
classmates
people,
called it mixers, like that? Okay, cool.
sure,
So over the
yeah, and so then
yeah.
within that, you would sort of hone your diagnosis, you would hone your adjusting skills with understanding it from this paradigm. This camp would hone their diagnosis and their adjusting skills
Okay,
from
so
this paradigm.
you tend to hone your skills and adjust your diagnosis and kind of base yourself in the mixer camp, so to speak.
Yeah, I practice as I see it as like if you went to an orthopedic physician who didn't have any drugs or any, not saying orthopedic surgeon, but an orthopedist who had no medication.
Meaning they're in their
That's kind of
toolkit.
what I was. I would diagnose low back pain. Yeah, I would diagnose low back pain, headaches. Here's the cause. You have facet pain. You have a disc herniation at L5 S1. We do or don't need an MRI. We do or don't need a referral to a surgeon. We're going to use these modalities to fix it. Here's your care plan, so to speak, for a disc. Here's what you're looking at for your risk rewards, red flags, that sort of thing. So I would treat specific to looking for an orthopedic diagnosis.
Have you heard the expression when you're a carpenter and you've got a hammer, all the world is a nail, or everything you see is a nail, right? And so it's
For
interesting
sure.
because you could almost make that argument, but then again, one thing you've kind of shown me before or told me, we've kind of discussed is, and I see this in myself is like, and this is just speaks to how complex medicine is and how complex the human body is. But if you come in with pain from what I perceive as an orthopedic diagnosis, as a trauma surgeon. Well, maybe that's not a good example because there's going to be a mechanism, and I'm going to know what injuries. But just maybe a general practitioner, which I'm not a general practitioner, but I in med school got to rotate. You might give for aches, quote unquote, aches and pains. You might give a very strong, powerful medicine. Now, in retrospect, right, Ketorolac or Toradol or something, it masks that pain or it goes away, but you never get to the true diagnosis of it. And sometimes, well, maybe a lot of times to a patient's detriment, because honestly, you don't know how to because you had this powerful medicine and you didn't really need to. You didn't have that powerful medicine initially. What did it made you? Did it
Yeah,
made you
I
kind of
find
dial in
that
and get, or was it, or did you feel like, oh no, it didn't do that. It didn't help me get better. It just made me go off on this other weird tangent. Where did you kind of fall in that?
I think it helped me really. In the beginning it was frustrating because you don't have certain tools. Like there are certain tools in pain management that orthopedists have access to that are really great and really effective. And like we all talk bad about steroid shots and Kenalog, but a lot of people use it and a lot of people get some benefit from it, and a lot of doctors rely on it because it works, right? I didn't have that tool, so I really, really had to hone my diagnostic skills. I had to get really good. I couldn't use the modalities that I would use for a disc if it was a facet joint. They just wouldn't work. And I couldn't use the modalities and the adjustments that I would for a facet joint if it was a disc herniation. So I couldn't just say, oh, you got low back pain, let me give you a steroid shot, walk out with a Medrol dose pack, and then call me if it gets worse. And then you never call me because it never got better, but you just knew I didn't have any tools. Like I had to really know it was a disc. No, it's not a facet. Don't do these things. Do these things. Let's treat you this way. So I had to get really good at my orthopedic diagnosis, I feel like, because I was competing against people who had really good tools. And so I felt like I had to get really good at my orthopedic diagnosis. And so I feel really comfortable with low back pain. It doesn't, I feel like I really honed my skill in those early years, and headaches and neck pain. That was my bread and butter. I really focused in on spinal pain. I did some extremities, but the majority of my work was pretty much spinal pain. And I feel like I got pretty good at that diagnosis because I only had so many tools that would only work for if the diagnosis was correct.
Wow, that's interesting, because if they came in elsewhere and to an allopathic practitioner who had steroid shots, Kenalog shots, or what have you, oral steroids, Torodols, gabapentins, non-steroidals, and then these other pain medicine for neuropathic type pain, and yada yada yada. They didn't need to know if it was facet or disc necessarily, right? And you could take care of both pain, and it's not like a patient can come in and say, "Doc, I think it's really my facet, not my disc," right? Right.
Right. They don't know. And I tell people, like, I had a patient just yesterday came in. And so I say this with a grain of salt because I think practitioners do this commonly. Like, I had a neurosurgeon tell me one time, it's like, what do you chiropractors do? Every time one of your patients come to me, they don't get any better. You guys aren't helping anybody. And I'm like, oh, that's funny, doc, because I get the same experience from your patients. Right. Because if you did really good with that neurosurgeon, why would you come to me? So I'm only going to see the ones who fail. So I start to think, oh, neurosurgery helps nobody. No discs get better with neurosurgery, because you do great. You're like back to life. You don't see anybody, right? So if you do great with chiropractic, you're not like, oh, let me go see the neurosurgeon for my low back disc because I got great. So only ones that go to him. So what the story I'm going to tell you was a grain of salt, right? So a lady came in the office yesterday, or her husband brought her in, and she's like, yeah, the orthopedist told me I had a torn labrum in my hip. And I was like, oh, geez, so they gave me a steroid shot. It helped for 48 hours, didn't get better. I was like, that's not good. It should help for a minimum of a couple months, right? 48 hours is not benefits, right? So then they said, well, you need to order an MRI with contrast. I was like, ugh, that doesn't sound fun. Not fun. Did an MRI with contrast, no torn labrum. So they said, oh, well, you just have some wear and tear in there. You have some arthritic processes going on. She's 27. We should do stem cells and PRP for $3,500. And I was like, well, hold up. Wait, let's just stop. Stop. I was like, maybe we need to step back and go back to that diagnosis end of the equation, right? So you don't know what's going on, right? They said it was a torn labrum, wasn't right. They said it, now they're just like, oh, it's wear and tear. Well, that's not a diagnosis. You're 27.
Was she obese?
I just talked to her a few questions. I'm like, this does not sound. Okay. No, not at all. Yeah, because she was a gymnast, a former athlete, and now, so we just worked with her for about 30 minutes, 45 minutes. And what I like to do is I like to pick a provocating position, like what in your life hurts the most. Okay. So if we're talking to you, like, and she's like, whenever I do the straddles and I lean forward, and she's showing her girls because she teaches tumbling. Whenever I sit in a straddle and lean forward, my hip hurts right here. It's awful. It's the most consistent. I do it every time it hurts. I said, all right, so let's see it. Okay, cool. We do some things and then we check that position. Do some things, check that position, right? That's one of the things I've learned on in my orthopedic. If I can make you better in the moment, I'm probably on the right track. And so we worked for 30, 45 minutes. We tried this, we tried that. It was not the easiest diagnosis. And so my rehab doctor, Dr. Anthony, was helping me. And we kind of ruled in a few things. By the end of the time, she's in a straddle, leaning forward and touching the floor with no pain. And we're like, without pain. So now, it wasn't like a miracle. I was like, okay, so we've taken 45 minutes and we just had the time. He had a cancellation, a no show. So he could help me. But orthopedist has 45 minutes to dive into it? And honestly, it, not to sound crude, but it was like a $75 visit. Who's got 45 minutes to spend on a $75 visit? You don't in the medical community, don't in the allopathic community, right? The way we set our clinic up, we have a lot of time, right? We do more of a concierge, more direct primary care. So the patient's husband was a patient of mine, so he was in the practice. I have a limited number, so I've got time. Let's sit and talk to your wife. So for me, that's like an example of, like, we got to take a step back and we have to get really good at the diagnosis, because she wanted to come in and she actually specifically wanted peptides because he had done really well on it. And I was like, yeah, let's pause, because if we do the peptides and it works, then we don't know why it got better. We need to know a diagnosis here. So I thought that was really important and it always has been important to find a true diagnosis so you can prevent future problems.
This is huge. And this is massive, actually. I'm glad that we just randomly ended up here, which is neat. But oh gosh, I have so much to say on this. There is so much orthodoxy and so much dogma and so much emotion and human and hubris and things that go into all these things here. Your discussion
Mm-hmm.
between you and the neurosurgeon. So it's interesting to juxtapose that experience with the neurosurgeon with, and I've seen that, and I've golly, maybe I've even been on that end. I think mine would be more like,
Sure.
right,
I think we all have,
we're
right?
human, right? But mine would be more like, hey, you're a chiropractor, but you're not like my brother, but that's a bias. But that's a bias too,
Right, right,
because
right.
but I remember in Ocala where I was at a level 2 trauma center, which operate like a level 1 in terms of busyness, for sure. Absolutely, it did. And we had some fellowship trained orthopedic surgeons, and there was one there I remember he would purposely send a lot of his post trauma lingering pain is not getting better to chiropractors. I mean, he routinely and other orthopedic diagnoses. And he just he I never got into it that much, because to me it was like, what you do, what do you want, to do, and on the surface and talking with him a little bit, it was just, he just knew they could get him better, and that he didn't either have the time or could,
Right.
but maybe it was all those things, right? But if we look at how complex medicine it really is, and if we're all honest with ourselves and we put our hubris aside, let's think about this for a second. Orthopedic surgery, neurosurgery, and all fields by that way are getting so complex as the medical. I mean, golly, I was reading a statistic years ago about the base of knowledge that represents the global or the universal knowledge that we have on Earth as human beings, and looking at the rate of doubling, and it's massive how much is doubling, to where it's in the, golly, I don't know, by now it's probably in the weeks. It's doubling. We're in terms of, you can count the doubling in weeks, like, every several weeks our total knowledge doubles. What?
Mm-hmm.
That's incomprehensible that any one person could know all that. Number one. Number two, as an orthopedic surgeon, as a neurosurgeon, just the things that they're doing in the operating room alone, in terms of the hardware, the metal alloys the hardware is made out of, the processes for putting them in, going from, or maybe human hands only, to now adding in robotics, or part robotics, part human, and on and on and on, is too complex for them to be able to, like you're talking about, do what, even know what you know. But then you've got this human emotion and the hubris, and just the different vices of being a human, right? Well, I'm fellowship trained, or I mean, I'm a double board certified fellowship trained surgeon as well, and I want to think that I know these things, but I don't. But you have a person here who does know them, right? So maybe we should all be kind of. I mean, it's easy to say stay in your lane, but you got to know your lane first, and you got to know what you're good at. Be okay with that, and just be okay with the fact that you don't know everything. Just like a chiropractor would have to send him to an orthopedist sent to a chiropractic. But it's all for the patient. We have to keep the patient as the center.
Yeah.
And when you do that, you tend to set up an environment where a patient's going to get a better outcome. So what I love about your clinic is that you do have the time, and it's not that, hey guys, it's not that your orthopedist is inferior. It's not that there's just too much. There's just too much for any one person to know. Plus, don't forget, yeah, there might be a reimbursement model and issues with that, but they also just literally don't have the time. If you got to wake up at 4 a.m. to get ready, to be to round on your patients at 6 a.m. at the hospital, to then get to the operating room by 7 a.m. because you got a full day of operations, you don't have, and then you got to go back to the clinic to see patients. You don't have time to spend with the patient like you do at Midtown Medical. But if you do have a Midtown Medical, which is unique, and you've got a person with extensive chiropractic, allopathic medicine with a nurse practitioner background, a rehab specialist with more additional orthopedic specialty and knowledge, and I can sit down and spend 45 minutes, you can really affect change, because you can find these diagnoses that, again, it might not be surgical. In fact, it's not surgical disease. It's medical orthopedic disease that needs medical and rehab medicine to treat it, not surgery. So clearly, a surgeon may not be as well versed in it, even though it feels like, as a surgeon, you're going to instinctively feel almost bad, I think, But once you accept that and realize, no, this chiro is part of my team, and vice versa. The chiro can say, no, the neurosurgeon or the orthopedist is part of my team, or view them as a team. I think you can affect better outcomes, and that's what I love about your clinic so much, is that you have. And I guess I'm tooting your horn a little bit, but I mean, seriously, it's a pretty unique position to be in, as somebody who is both a nurse practitioner and a chiropractic. So you can stand in the middle of that divide and reach across the aisle, so to speak, and integrate that into a medical practice. And I think that may be part of the reason why you have such good outcomes. Sure, you're committed to the truth. Sure, you're committed to the patient, but also it's the setup and what you've committed to yourself to acquire the knowledge from the chiropractic orthopedic side, acquire the knowledge from the allopathic side, and then integrate them. Am I going off on a tangent and singing your praises unnecessarily?
Yes.
Well, I mean, or do you think there's something to that?
Well, I think we've gotten to a point in medicine where if you ask the patients if they like how it's set up, and I don't deal with trauma, I don't deal with surgeries, right? So we're not talking about that. But if you ask the patients if they're happy with it, or if you ask the doctors if they're happy with it, both people would agree, no, it's terrible. I can't, I don't like this. I go and I wait. It's terrible. The doctor has no time. The doctor says, I'm so busy. I don't have any time with my patients. But we're all just keep doing the same thing. Our outcomes are terrible. Our happiness from a patient perspective is terrible. Our happiness from a doctor perspective is terrible. Neither one of them like it, but we all just keep contributing to it, right? The only one that's happy is Blue Cross Blue Shield, right? They're making billions. United Healthcare is completely happy. So they're the only ones who are happy, but nobody's doing anything different. So I learned early on in my rotations as a nurse practitioner, I was just like, this is awful. Have been a chiropractor for 10 years by that time. And so I was well versed with the patient interview, and I had 10 minutes with the patient, and they would often come in with 2 or 3 issues, plus some sort of check I had to do for some insurance guideline. Right. And I got 10 minutes with them. Like, are you kidding me? It was silly. And so I just I can't participate in this because I'm just going to propagate the exact same thing. Patients aren't happy. Doctors aren't happy. Why continue to do it? Whether or not I was successful with changing that model was irrelevant, because if I was scared of doing it because I wouldn't be successful, so I said, well, I'm not going to do it. I'm going to participate in this system and I will be monetarily successful. I am insuring my unhappiness. If I participate in the current medical model of primary care, I am ensuring that I will be unhappy. I've never to date, and I maybe they're out there, I've never met a primary care physician or a patient of traditional primary care was like, this system's awesome. I love it. I've never met them. So my options were maybe ensure my financial success. Maybe, I work for an HMO, have a guaranteed patient-based guaranteed income, and I would ensure some financial success, but I'm also guaranteeing that
your patients are going to be unhappy.
Or I can take a risk, and no one's liking it, or I can take a risk, maybe not be financially successful, maybe, but I can at least affect and have some influence on whether or not this will work for my patients and work for me, and we can both be happy with the outcomes. And so it doesn't work for everybody. Sometimes my patient model of care is not what the patient needs or wants or is ready for at the time. Sure. And so, it's not for everybody, but this system was not for me. And I would argue this system is for nobody, because I've yet to meet the person who's like, I love it. My primary care, the traditional model, is just kicking butt, and they're happy to spend all the time they have with me. They're super right. And then the doctor's like, I love it. I have all the time I need with patients. Right. So the only people who are happy with this are the major medical insurers, because they're just raking in billions and, getting government subsidies, and it's silly. But so I don't participate in the insurance model. I don't participate in it. I would say it can be as financially rewarding as it is emotionally and patient rewarding as well. Maybe I would be doing better if I did HMO participation or something like that. But I don't know that to be true.
Are these thoughts that you had at the time, way back when you decided, or that in now retrospect you did? And why I asked that is, I'm just wondering, why did you specifically decide to go back to? In fact, as I recall, you were pretty successful as a chiropractor. You had a very kind of booming practice where was bringing in other chiropractors, supporting other chiropractors because you had so many patients and people loved you. But why did you decide to go back to nursing and then nursing practitioner school? Was it because of these thoughts then, or what was the?
No, when I went to nurse practitioner school, I just became at a point in my chiropractic profession where I was limited in the patients who were coming in. I was too limited with my scope of practice. The scope of practice for chiropractors is really narrow. You can really only do lifestyle change and manual manipulation. That was about really the brunt of what I had to do. And so I would have people come in with separated shoulders, and I'm like, I can't reduce that. And I remember patients would come to me, like I had a primary care, a patient said their arm, called their primary care, said, my arm is killing me, I got to come in. She came in and she was like, she was necrotizing fasciitis and she was septic. Like, I was like, what, but she had reported to her primary care, not knocking the primary care, their arm hurt. And I was like, you've got a giant open wound there. Like, you shouldn't have said my arm hurts, but
it did.
And then I had someone who came in with a headache and they had, right. I was like, that's the most ridiculous history. Patient came in and brought, I had helped them and they said, oh, my brother's head's hurting. He came in the office, talked to him a few minutes. He was completely out of it. And I did my physical exam. He had a giant gaping wound in the back of his head. He passed out this morning and hit his head. I was like, what are we doing here? So like I was getting, these weren't everyday occurrences, but I was getting more and more of these because I think I developed relationships with my patients. They trusted me. I helped them with their disc. So they're like, hey, will you do stitches on my son? He hurt himself with a baseball game. I'm like, no, I won't. I don't know how to do stitches. Like my mom sewed my clothes, and I don't have any lidocaine. I don't have any antiseptic. But I just kept running into these things. And then I honestly came to a point and chiropractors won't like hearing this, but I came to a point with some of my really acute patients who maybe I could help, but there was a need for a quick medicinal pharmaceutical fix at the moment. I did start seeing with the patients that came to me in the beginning, they wouldn't come to me. As I got more, maybe in the community, more and more trust, people were like, man, I'm dying. And I was like, I can't do anything. You're just in too much acute pain.
To even diagnose what's going on. Right.
And so, yeah, you're just frozen with a low back herniation. And I was like, so I started sending people back to their primary cares. I had a letter written. I was like, will you do a Toradol shot? Will you do a cortisone shot? Will you evaluate them for some pain meds? Because this is just not working. So I was like, well, I need some more tools in my toolbox because I'm running into a lot of these issues that the chiropractic profession couldn't handle with a manual manipulation. Like patient was coming in, their low back pain was clearly of psychogenic origins, right? They just had whatever and I was like, no adjustment in the world is going to fix this. I can't, you know what I mean? Like if your kid gets sick when they get a stomach ache when they go to school because they don't like school and they don't like what's happening there. It's not that they have indigestion or not that they have irritable bowel syndrome. It's the school's the problem, right? This relationship here. And so I was running into that with adults and I was like, I don't have enough tools and I'm finding all these reasons that I need more tools. Yeah. So I originally went to PA school. So I originally applied to PA school, didn't get into PA school. Chiropractors, unfortunately, we shoot ourselves in the foot a little bit academically. So I couldn't transfer my credits to PA school. So I went back all the way to nursing undergrad, took a sabbatical from work, took 18 months off my job, traveled to Northern Alabama, enrolled in a undergraduate nursing program, and then followed up with my
So were people seeing you? Is it safe to say people were beginning to look at you as their primary care physician? Your patients, because it sounds like if they're coming to you with these diagnoses, it's like they're seeing you as their
primary care, but really orthopedic. I really
no. The patients, they were coming to you with wounds and
sure, but they were all of orthopedic. Like they were always separated shoulders. They were lacerations. They were severe low back pain. They were, maybe diabetes, neuropathy, but to them it was a musculoskeletal, feet hurt, So I was running into these, but they were strictly orthopedic.
So they were coming.
Yeah, but I couldn't manage someone's diabetes because we in chiropractic school we like to really bash the traditional medical, right? Oh, it's terrible. You shouldn't do medicine ever. Shouldn't do this, And for me, my experience was, well, yes, but I was treating a very limited patient base. And then when that broadened, I was like, oh, some of those tools that you guys have over there that my professor said I shouldn't ever do, they're actually not that bad. And maybe if I learned about them, instead of saying, oh, all medications are bad, I could say, well, actually, the one you're on is not the best. I would actually switch it to this. And here's the reason why. Or I have the knowledge to say you don't need this. I can accurately say you don't need this. As a chiropractor, I would philosophically think that potentially, like, oh, you shouldn't be on all these meds. But I really didn't understand the pharmaceutical basis of those meds. I didn't know what an SSRI
it was dogma.
I didn't know
So
what
you're saying there's
diabetes
dogma in
medication was.
chiropractic too, just like
Yeah. Oh, for sure. Right. So, but then when I went to nurse practitioner school, I started to get the knowledge base, and I can say, yeah, like yesterday I had a guy and he was on metformin, and I was like, why are you on metformin? He goes, I don't know. I said, I looked back and I pulled his labs for a couple years. I was like, your A1C's never been over. Why are you on this? And he's like, well, my doc said I may have metabolic syndrome. And I was like, okay, do you like it? He's like, no, it gives me indigestion. It gives me nausea. And I was like, so you don't know why you're taking it. I can't see a reason. I said, well, I'm not going to take you off because it's not your primary care. I'm not the one who prescribed it, but go ask them why you're on this and get a good answer. Maybe they have a good reason and you need to know it, or maybe you need to come off it. But I couldn't have done that as a chiropractor. I didn't know to look at an A1C. I didn't know what an A1C was. I didn't know to look at their glucose. I didn't know what metformin was. I didn't know what, I couldn't have said what glucophage was. I couldn't do those things. And I was like, well, if I really believe that, if I really believe they need to be off medication as a chiropractor, and I really believe steroid shots are not the ideal, then maybe I should go learn it. So that belief is based in actual knowledge as opposed to belief based in dogma that somebody else told me.
If I'm going to believe this set of ideals, I'm going to practice what I preach, and I'm going to know people are coming to me with things that I can't treat, or at least not as completely as I want to, or they want me to. I'm gonna be that provider that I'm gonna be offer more comprehensive care. The patients deserve that. They want that. I can do it. I'm gonna go to NP school. I went to NP school. I'm finding now that I'm integrating my NP and my chiro together. Do you think that being a nurse practitioner makes you a better chiropractor? Number one, and then on the flip side, do you think that being a chiropractor makes you a better? I say, wait, do you think, but you know what I mean? NP,
yeah, both ways.
you think so? Give me an example of why.
Yeah, both ways for sure. I think chiropractic really, because I couldn't rush an exam. Like I had to do a real full, thorough history because I had to dig into
it. Tools,
right? My tools were limited. I had to do a really good orthopedic assessment and orthopedic treatments. So it taught me how to relate to patients. It taught me about effecting change. You can't just tell somebody that comes into you overweight, you need to lose weight. All right, see you next year. Okay, lose weight. Like I know that. Like give me some tools. And so, like it taught me how to relate to patients. It taught me how to understand patients. It taught me to be able to have their best interests in mind. And then so then when I'm now a nurse practitioner, I have some of these other tools that are available. I can take a more advanced case of chiropractic and treat them with this. And then as a nurse practitioner, I can take the time, and I've learned the value of sitting down and diagnosing and talking to a patient, understanding where they're coming from, and some of those other things that maybe the allopathic world just doesn't. I think they just, for whatever reason, have set it up so poorly. They, saying you don't have time is then make time or quit saying you don't have time, right? It's one or the other, but they're not making the time to do. And so both of those have informed both sides extremely well. So I still use, I do Toradol injections, right? I still do Kenalog injections, but I'm like, maybe we pause or yeah, we need it. So I'm able to make that decision a little more effectively. So you can come get an adjustment and an injection if you need it. Or you can say, which one do I need? You can do both. Tell me which one's the proper one. If you go to a chiropractor, they can't do an injection. If you go to your traditional primary care, they can't do an adjustment. So how do they know if it's appropriate or not? You don't really know. And so it also just sort of let me have a wider breadth of tools in my toolbox that I can be applied at different points. And I know the effectiveness of both of those.
So early on, it seemed like integrating those two allows you to provide more comprehensive care to your patients. If they need an adjustment, you could do that. If they needed medicine, you could do that. If they needed both, you could do that. So now you've gone from just spinal and soft tissue, etc. manipulation and their associated diagnoses. Now you can use allopathic protocols, medicines, techniques. Your scope of practice has increased. You're able to offer more comprehensive care. In the early stages, as I remember, visiting your clinic and seeing that was a big step forward. But now there's even another. You've kind of transcended that model into even another state of what I would say another level of comprehensive care, really, in Midtown Medical. Explain your new clinic and how you have it set up. What modalities are you specifically using? How do you use them? I know you've got a rehab specialist. You do have a traditional chiropractic clinic as well as this new multimodality, or excuse me, multimodality, multidisciplinary treatment. And you're using movement as medicine. You've got the traditional allopathic medicine. You've got rehab specialists, and you're also using, I believe, heat, cold, and maybe I'm missing something.
Yeah, so my new clinic I have a rehab doctor there, so we still see some of those orthopedic. It is a gym, so we do personal training. We've sort of integrated those two, so we do what I call a higher level of personal training. We don't have a lot of people who are just using the personal trainer as an accountability. Although that's an amazing, I don't work out unless someone's telling me to do it, right? But ours are a little step above that. So we have, you might come see my rehab doctor for an ACL tear, and you didn't recover well. He's knowledgeable about that, knows the protocols, knows the steps, and then he has personal trainers so that you see him, and then you might do an hour and a half session in our gym, and then you see a personal trainer, and you're still working out, but that personal trainer is informed by the rehab doctor
who's
about
on
specific
site
protocols
right there.
and things with
I mean, that's a big deal.
Yeah, and has trained them. So yeah, and we're also doing, like, we're piloting this program. Actually, my daughter Bird is doing it with a chiropractor. He's going through low back. They did low back education, just in-house education for a few weeks. Then they're going to do shoulder. Then they did knee and low back so far, and then they've just started hip, and then they're going to do joint specific.
God, this is new to me. So Bird and the rehab specialist are they classes, or what are these?
Yeah, they meet once a week, and he has an education pamphlet that he wrote up from a PowerPoint that she has to learn and study on her own. Then they come and meet on Fridays, and they discuss movement screens. They discuss range of motion techniques and workarounds. They discuss diagnoses. The rehab doctor and the personal trainer, who is Bird at this point. She's piloting it.
She'll take that to her clients or patients, or how?
Yeah, she just uses it with her clients. So when a client comes to her, she's just, we're trying to find that sweet spot. Like, you don't have diagnostic criteria. Do not diagnose, right? But if someone says this to you, you're just educating yourself. You're educating yourself. You're educating yourself. And if Dr. Anthony knows that you're doing personal training with one of his patients, he can feel comfortable that you're not going to do something maybe improper, or you have a resource to go to, but you also have a resource within yourself that you've learned. If a disc patient presents like this, don't do this. If a disc patient presents like this, try this. Here's your red light. Here's your green light. Here's your yellow light. And so we're just doing in-house education programs.
Hold on, let's stop.
So that we can train our PTs.
Hold on, so you can train your PTs. Hold that thought, because I'm sorry to interrupt you, but this is important. I'm going to have to toot your horn again, because I have to. This is incredible. Nick. I have not heard of this before. I got to stop for a second, because this is important. As a trauma surgeon who sees all types of injury, one of the things that interests me and was one of the driving forces for me to ask you to team up on this Vitality Code podcast was trying to crack the code to vitality as you age in all different categories and modalities, and approach aging and general vitality as a human being in a comprehensive way. And one of the things that I've been thinking about for a long time, is we are so bad at prevention. There's so much information on prevention. There's a lot of research that goes into prevention, and I say let me first say me, as whatever my role is as a health care practitioner, and my role as a trauma and critical care surgeon, EGS surgeon, robotic surgeon, general surgeon, etc. And then the clinic that we have here in Myrtle Beach. One of my goals is to get better, but I'm bad. And I think that a lot of people are bad, not because they mean to, but because the healthcare system is set up this way. We're very good at treating acute disease. very good, but preventing it is another thing. And as we age, there's so much that can be done to prevent. One of the scourges of the healthcare system, the trauma surgeons, but more so than that, is the patients themselves. Is as you age, the most likely way in which you will incur a traumatic injury is a fall. And man, I cannot tell you, there are, to prevent those, and if you look at the orthopedic diagnosis, if you look at the surgeries that orthopedic surgeons are performing on people as a consequence of osteoarthritis and aging and those types of things, you're going to see certain joints. You're going to see, it's classic, right? It's always the shoulder, always the hip, always the shoulder, always the hip, and the knee, right? So you take a look at those three, and then those lend themselves to, if there are motor weaknesses or ways that you've adapted in terms of aging, antalgic gaits, antalgic ways of moving your body, and then that becomes not a good thing. It becomes a bad thing where it's maladaptive, but you just do it because of pain. Then you get weaknesses other way. Your gait becomes weak. Your grip strength, the way you use your shoulder, the way you use your hip, the way you use your knee, and then you have a fall. And then on and on and on and on and on. So what I've always thought is that somebody should, turns out somebody is, just take it down by the joint, each joint, and what you should do to keep those strong and healthy over the years, to hopefully either push back the time that you would need surgery or not have surgery at all. And number two, help them with the basic motor skills and motor strength involved in gait and balance in their daily activities of life. And you're doing it. So if you're in Tallahassee right now and you're hearing this podcast, or if you're in the surrounding area, get to this clinic. If you want to prevent fall, I'm serious. If you want to prevent falls as you age, and I'm telling you, it's a big problem, because you know what else comes with aging is stroke risk, accumulation of morbidity. So now you're not only falling, you're falling, hitting your head, having a brain bleed. I mean, on and on and on. And it's not insignificant. This is a huge thing. It's getting more and more. The fastest growing demographic is this over 55 or over 65. These people are going to be at high risk for falls. Get to Midtown Medical. Get with this program. Strengthen. Get joint specific analysis, and then joint specific treatment regimens to strengthen those joints, and reap the benefits because of it. So I'm sorry to interrupt, but that was so profound to me, because you're way ahead of the curve, at least as I know it. I've never seen anything like this before or heard of it. Tell me more. Again, I'm so sorry to interrupt you, but you were talking about your PTs. You take that information now and you go to your PT side, and how do you integrate there?
Yeah, it just allows them to have a better knowledge base. And so you can't see, there is a hierarchy. You can't see a lot of people want to train with our rehab doc, and he's like, I don't have an hour to train you, but Montana can, and she works with me, and I'm in the room, and we can adjust that. And so we integrate those modalities that way. We try to integrate our modalities, right? So we have a sauna and we have a cold plunge on site, and so they can integrate those. So I may have a patient who is seeing me. I think of a specific guy that's coming to my mind, and he's an older gentleman, and so cardiovascular risk is a specific risk for him. So he's seeing my personal trainer for that. But I also tell them I want him in the sauna. Every time he's there, he's got to be doing 20 minutes in the sauna, because there's some great data on cardiovascular benefits. The sauna is up to 20 minutes. Yeah, you want to do about 20 minutes each session, and you need it to be hot, and you need to do about 3 sessions a week, so about 60 minutes a week. So they're integrating that. So it's like, this patient is seeing me, I'm balancing his hormones, I'm not his primary care, but I'm also acute, understanding what's going on in the cardiovascularly, working on his blood pressure, working on some arterial issues. And so I'm like, you need to see the personal trainer and you need to use the sauna. So we're sort of integrating those things. He's a really high stress individual, really high stress, which is definitely contributing to, again, the cardiovascular issue and just his overall health. And he tends to get sick at particular times. And so he's working with our somatic therapist. And so I'm like, you need a avenue to relieve the stress. You don't have any tools in your toolbox to relieve stress. And so when that bottles up, it comes out in you as physical sickness. So the exercise relieves some of that stress. You're also going to see my somatic therapist. And so she can teach you some at-home breathing techniques, some ways that you can avoid these so you don't run into those same things. You don't dive to work, because that's what how you deal with stress, but it also produces more stress. So it's like a self-feeding cycle for him. So we're trying to integrate a lot of those modalities. And then we also have a CrossFit side to our gym where we do really intense exercise. CrossFit has certain connotations to it for different people, but for us, it is really a great way for us to apply strength training, cardiovascular training, skill training, and an occasional intensity modality that really is widely applicable to people across every decade of life. And we have 20-year-olds, we have my daughter who's 17, and then I have members who are 68, and they are in the same class together. So it can be done regardless of what you think about CrossFit, but intensity is just different for different people at different points in their life. Like what's intense to my daughter might be at a higher capacity than it is for a 65-year-old. And sometimes, though, what's really intense for my daughter is like, I can do more than that if it's a weight-based thing, So, but then you put her on a gymnastics apparatus and she's working my butt, and I'm struggling over here trying to do kip swings, and she's doing muscle ups. So that intensity switches depending on the day. And so that's where our coaches step in, and we have an educated coach base that kind of helps you lean towards personal intensity for that day. That intensity is determined by psychological as well as physical tolerances for the day. And so we've tried to really integrate exercise, these self-care modalities such as saunas and cold plunges, physical fitness, and then with the overarching theme, we do a lot of hormone replacement. We do some weight loss, and we do some peptides. Those are probably the big things that we are using. And then we integrate that with a little bit of a primary care approach.
That's awesome. We're running out of time, but I cannot. The more I learn about Midtown Medical of Tallahassee, I want to get a Midtown Medical in Myrtle Beach. I mean, this is seriously, and people are going to say, "Oh,
you're coming down in December, aren't you?" So
now, yeah, I'm coming down in December.
We'll have to put you through their
we're going to do it, and we're going to give you guys an inside.
I got a hyperbaric chamber too.
I got a hyperbaric so we're going to roll back the curtain. So upcoming guys, we're going to roll back the curtain on some of this, let you see it firsthand. There's going to be the naysayers out there. Oh, you're his brother, so you're just saying it. No, I'm telling you, as a, and whether you believe me or not is inconsequential. Just look at the data, look at the reality. There's a massive need for this. There's not a lot of people who are doing it, and there's not a lot of people who have been doing it this long, and they're as good. And that's why I asked Jeff to do this project with me, and I'm so grateful. They said yes, but I'm more excited to roll back the curtain on this and take a look and show you guys what life could be like if we can all do this together. And that being said, again, COVID put a lot of this in stark relief for us, and in the world in its entirety. And on one of those,
Sure.
one of those things that it really told me, or it kind of showed me, is what a fragile state of health, Jeff, that we're living in. When I say we, I mean the world in general, and maybe we don't know it because, like I was talking with producer Nick about, our sedentary lifestyles because of our awesome technology and all these advances we made, maybe have had to detract a little bit from our physical fitness and our well-being. Wasn't ever meant to be. It was meant to be progress, and it is on some levels, but probably had some repercussions as well. And one of those big repercussions I see, I mean, everybody sees it, is obesity. And I think that Midtown model can not only help with the vitality and these orthopedic conditions and stress, and it all ties into obesity in general. But there was a 2014 McKinsey report that I came across in reading just the other day, describing that, and this is in 2014, if the trajectory that we were on then, which ends up we are, that by 2030, half of the entire world's population will be overweight or obese. It's insane. It's insane.
Yeah, it's wild.
Insane. And if you look at the economic impact, the three top economic detractors from a health perspective is smoking. And by the way, I'm not in this order necessarily, but smoking, firearms as this relates to homicide, suicide, war. I mean, I'm not getting into that debate because in the report it's all encompassing, the whole thing, and then obesity, and they're all the same. So obesity is, now this was in 2014, so I don't know what it is now. Obesity was the same as war, same as suicide by gun, homicide by as obesity.
That's wild.
You're talking $2 trillion each of those. I mean, insane. Something that is largely, and almost completely preventable. But I want to dive into that over the next.
Yeah, we've just started our clinic. We didn't, for whatever reason, didn't do a whole lot of weight loss clientele in our. We've just started to obviously new medications out there, semaglutide, tirzepatide. I really resisted those in the beginning.
Yeah.
If I was truthful, I had a patient who came up to me and was like, I just didn't talk about it with patients. I didn't really give it as an option. I didn't really want to go down that. I had some personal biases that were influencing that decision. And so I remember my first patient I prescribed semaglutide to, she was like, well, tell me medically why I shouldn't do this. And I was like, I don't have one. She's like, so it's just your opinion. And I was like, you're right. So I said, okay. I said, you called me on my, and I'm willing to change. So, as we've just started to dip into this, the semaglutide thing is wild. Like, I'm late to the game. We've written quite a few prescriptions now, but I know you've been doing it longer, and I'd love to hear some of that research on it. A couple of things that I've noticed is patients are doing great on it in terms of weight loss. There are some pitfalls that we've tried to mitigate, and we're trying to be, I'm not an early adopter, so I had a little bit of, people that were testing it and finding the pitfalls for me. So there are some specific pitfalls, but I know there's a lot of questions. And my trainers were like, a lot of things, we talked about this last time, is can you even work out while you're on this? What are the pitfalls? Do you have to be on it forever? What is this medication even doing to me? Is it safe? Do I have to be on it forever? But patients are losing a significant amount of weight on this tirzepatide. I think I'd like to discuss like some of the science with you, and then maybe bat around some of these ideas of like, what is the long-term implications of this? Will it be a fix? I mean, those are questions. And if someone's on the fence, again, I don't tell patients what to do. I just give them the information. I think they need to have adequate information. Like, what is the pros, the cons, the risk, rewards? What are the benefits of them? What are the potential things they might run into? So it'll be interesting if you could maybe elucidate in some of that research
I'm
for us on those two things.
I'm excited to illuminate some of this. And as I've been looking over it, I think you guys have the right setup in Tallahassee to affect long-term change that's lasting and can be more than just the medicine itself. I too was a big, I didn't want to accept it. I didn't want to, why can't you just change why can't you change your habits? Why can't you,
right.
And then I looked at myself and said, yeah.
Do it the way I did
it. It's much more than that now. We need the medicines. They're powerful, but the life-changing systems that to be in place to keep it lasting and so forth are important too, and the two work together synergistically. I am so stoked to talk more about this, and I think it's going to be honestly, the information is so massive to go through and so important and fascinating. It might take us a couple podcasts to get through it all, but we will. And I mean, let's dive right into that next time. What do you think? All right, man.
Sounds great, Doc.
Been fun. All right, bye.
All right, be good, brother. Bye.